So moving on, now I would like to welcome our next two speakers, Michelle Chan, Quality Assurance Pharmacist at the Massachusetts Board of Registration in Pharmacy, and Julienne Tran, Pharmacy Investigator, also at the Massachusetts Board of Registration in Pharmacy. So you can take it away.
Good morning. Thank you. We really appreciate the opportunity to speak with you today. Before we begin, I'd like to introduce our new Executive Director here at the Board of Pharmacy, Michael Godak. Mike, if you're here, would you like to say a few minutes?
Thank you, Michelle. Can everybody hear me? Nod, yes? Yes, okay, great. So, hey, I just wanted to take a quick minute here being the new guy on the block, so to speak. So I've seen a lot of names in the chats, a lot of familiar names there. So good to see those names and nice to meet everyone else virtually. As Michelle said, my name is Mike Godek. I am the new Executive Director of the Massachusetts Board of Pharmacy. And I just want to take a quick 30 seconds or so before you get back to your learnings here and get in front of you all and just introduce myself. So I've been a pharmacist in the state of Massachusetts for over 30 years. Within a large chain in various roles. But within that time, I also had the opportunity to sit on the board as a board member for approximately 6 years. And that's where I really got the passion for doing what I'm doing right now. So I just wanted to say I'm excited to be here. My door and the board staff's door is always open for any kind of questions that you may have. But again, just wanted to take this opportunity to say hello and welcome everyone to the seminar. JT and Michelle, you'll be in good hands with these two. So thank you very much.
So good morning again, everyone. My name is Michelle Chan. I am the Quality Assurance Pharmacist here with the board. We have several objectives today. If I can figure out how to advance the slides, we'll be all set, right? Here we go. So JT and I don't have any disclosures to make today. JT is Julienne Tran, so we all call her JT, so you'll hear me probably refer to her that more than once. Our objectives today are to identify the differences between legislation and regulations, describe the process on how to implement new and revised regulations, and summarize new advisories, policies, and circular letters. So our mission statement is to promote, preserve, and protect the public health. Really, at the end of the day, that's really all we do. And we do that. We do that in several ways. We ensure education and experience through the licensure process. We issue regulations in order to outline our safety expectations, and we inspect our pharmacies frequently for compliance. So we have a whole bunch of common terms that we throw around. We have legislation, regulations, circular letters, policies, and advisories. So I'm going to go over each of them and explain the differences between them and, more importantly, how it affects your practice. So first we have legislation and regulations. So legislation, in Massachusetts, legislation is MGL, or Massachusetts General Laws. Legislation is also referred to as statutes or laws, and it's enacted by the legislature, which, we vote into office. So when a bill becomes law, the law generally provides only a general framework as to what the legislature wants the environment to be. Generally, it doesn't provide a whole lot of detail. Sometimes it does, but generally it does not provide a whole lot of detail. That's where regulations come in. In Massachusetts, the regulations are CMR, or Code of Massachusetts Regulations. And the regulations have the same effect as law. They are required to be followed, but they give a little bit more detail on how to put the law into effect. So it'll provide a little bit more detail of, if you think of the law as the what and the regulation as the how-to, they kind of go hand in hand. When legislation is put into effect, that's done, like I mentioned earlier, by the legislature. But the regulations are developed by the Board of Pharmacy in our case. They're written by board staff. We have input from stakeholders, and the board will eventually decide on how they want the final document to look. One very important difference between legislation and regulation is that regulation can be waived, whereas legislation cannot. So the board has no input to legislation, so they can't waive it. Regulations, however, can be waived if you have a a solid reason as to why the board would offer you the ability to waive it. Also, for legislation, the general public does not have input into when laws are made. Regulations, however, when they're written and the board reviews them, there is an opportunity for a public comment period. So the public can make any comments they want to when before regulations are put into effect. So as you may know, we have a whole bunch of regulations that were put into effect as of December 6th of last year. We have updated regulations at 247 CMR 6, which involved licensure of pharmacies, Section 9, which was general practice standards, and Section 15, which had just a few tweaks, and that was the continuous quality improvement program regulations. There are a brand new set of regulations at 247 CMR 20, which are reporting regulations. And 2 regulations were rescinded. So that was 247 CMR 5, which talked about PMP and electronically and orally transmitted prescriptions. Those requirements are found elsewhere in regulations. They were pulled into 247 CMR 20, that new section. And they're also outlined in DPH regulations at 105 CMR 721. There was also an old regulation on the books, 247 CMR 12, which involved a restricted pharmacy licensure. Restricted pharmacy dealt with, pharmacies dealing with a pension plans or trust funds. I don't think I've ever seen it actually in practice, so that that regulation was rescinded as well. So the first revised set of regulations is 247 CMR 6. So that was new license types. So now we have licensing of not only drugstore pharmacies, but we also have sterile compounding pharmacies and complex non-sterile compounding pharmacies. So the way the law was written, those are licenses that are on top of the retail pharmacy license. So they're in addition to. So if a retail pharmacy does both sterile and complex non-sterile compounding, they need to have all 3 licenses, the retail, the sterile, and the complex. For the first time now, we are also licensing institutional sterile compounding pharmacies. The Bureau of Healthcare Safety and Quality will still have licensure over institutional sterile compounding pharmacies and institutional pharmacies in general. This will be an additional license just for the clean rooms, for the sterile compounding rooms. So we'll be looking at basically just the room structure itself and the practice in that room to make sure that things are compounded properly and in a proper environment. We are also starting to license non-resident retail pharmacies, non-resident sterile compounding pharmacies, and non-resident complex non-sterile compounding pharmacies. And all those licenses, again, are in addition. So everyone has to have a retail pharmacy license, and the sterile or the complex non-sterile licenses will be in addition to that. Section 9, we updated the professional practice standards as well. So there are some new items in there. So counseling is now a requirement for each new drug therapy. So whereas before only counseling had to be offered, now it's a requirement for new drug therapy. So it's not necessarily a new prescription for ongoing therapy. It's brand new therapy, like a new start for metformin or a new start for amlodipine. That is now a requirement in the new regulations. Pharmacies are now required to transfer a prescription in a timely manner, whereas before it was only a recommendation. Now it's a requirement to do it in order to to prevent any delays in patient therapy. There's also a statement in the regulations now that say you cannot charge a fee to transfer prescriptions. Pharmacies are required to take back medications only if they're dispensed in error or defective or contaminated. Before, we did not allow pharmacies to take back anything, but for patient therapy, this is something you can do and replace it. You cannot put it back on the shelf. It does need to be disposed of properly, but you can take it back for a patient and correct the error. As you know, Schedules 3 and 4 federally are only valid for 6 months or 5 refills. There was never anything on the books for Schedule 5, and now there is. So now Schedule 5s will be treated the same as 2s and 3s. They're valid for only 6 months or 5 refills. There was never anything on the books for Schedule 6. I think it was urban legend that it was only good for a year, but now it's actually officially in the regulations that Schedule 6 prescriptions are valid only for 1 year. Managers of record of a pharmacy are now required to work an average of at least 30 hours in their pharmacy. And that's to make sure that they know what's going on in the pharmacy. They're the boots on the ground, making sure that everything is done properly and in accordance with board regulations, and being basically a leader of that pharmacy. Some other language that was updated was about licensing. Licensees are not permitted to work more than 12 hours in a 24-hour period without an 8-hour break. So this is all licensees. This isn't just pharmacists. This is pharmacists, interns, and all technicians. So no more exceeding 12 hours without an 8-hour break. Unless, of course, there's an emergent reason to do so otherwise. New section 247 CMR 20, which has reporting requirements. The goal of this section was to pull the reporting requirements from all the other specific sections and put them in one spot. So you kind of have one-stop shopping as to know what to report and what time frame you have to report it. So serious adverse drug events. So if there are dispensing errors that result in a serious injury or death, or one that results from a compound, those will have to be reported to the board. Changes of manager of record or a designated pharmacist in charge have to be reported as well to the board. Manager of record is the term that we use here in Massachusetts for basically the manager of the pharmacy. The designated pharmacist in charge is a term we use for non-resident pharmacies, which is basically the one Massachusetts licensed pharmacist for the non-resident pharmacy to ensure compliance with Massachusetts regulations and laws in that state. But that person does not have to be the quote unquote manager of record of that non-resident pharmacy. It can just be any licensed pharmacy. It doesn't have to be their manager. In Massachusetts, we do require that the manager of record personally notify us when they leave a manager of record position. And the reason for that is so that we know that when you are no longer responsible for that pharmacy, and that we'll be on the lookout for changes of for paperwork changes from the pharmacy. So this is a protection for you, so that we know when you are no longer responsible, and we should be looking to see who the pharmacy is going to report to be their new manager. So that is just more of a protection for that pharmacist leaving the position. Individual licensees are also required to keep updated their name, addresses, email addresses, and all their demographic information. And you will do that through the licensing portal where you renew your license now. Other things that have to be reported by individuals would be any disciplinary action, CE deficiencies, arrests, criminal charges or convictions. But there's no requirement to report employment changes to Massachusetts. I know other states do have that requirement. We do not. All pharmacies are required to report also disciplinary action or loss of certification or any accreditation status changes. They're also required to report whether, if they had an inspection by the DEA or a visit by the DEA or the FDA, maybe they got a warning letter, any correspondence to that effect, they should be notifying the board, of any information they get that's non-routine information or even routine, such as inspection reports. In Massachusetts, controlled substance losses have to be reported. Pharmacies in other states will have to deal with their reporting processes in other states, but in Massachusetts, you report losses to the board and to the DEA, depending on what the drugs are. Compounding pharmacies are required to report a list of all the products that they dispense into, within, or from Massachusetts. And going forward, that will be done every year upon renewal, because compounding licenses are only valid for 1 year. So it'll be embedded into the renewal form. So you'll see when the renewal period comes up, you'll see how it'll be done, and you'll be able to put that information right into the renewal form. Massachusetts located pharmacies are also required to report to which states that they dispense and the status of those non-resident licenses. Compounding pharmacies also have to report defective compounds that have been dispensed, and all sterile compounding pharmacies have to report if they have an action level report, a USP action level in the environment, whether it be microbial or particulate. And they also need to let us know of any failed recertifications of their hoods or their other ISO classified rooms. Prescription basics. So I just want to quickly go over the differences between prescribing and filling requirements because they are a little bit different. So I'll talk about that in a minute. It can be a little bit confusing. So prescription requirements are obviously what the prescriber needs to do. This is what their job is as the prescriber. So they need to have on the prescription the no substitution language, the name and address, the prescriber MCSR number or the DEA number. So the MCSR number is the Mass Controlled Substance Registration number. Every prescriber in the state needs to have that number. If a prescriber is only prescribing Schedule 6, then that's the only number they need in order to fill a prescription here. If they also obviously want to prescribe a federally controlled substance, they also need a DEA number. But just so that you're aware, there are prescribers who only have an MCSR number because they don't prescribe federally controlled substances. So just so that you're aware of that. Date issued, you need to have the date issued, like the actual date the prescription was issued, as well as a do not fill before date if someone doesn't want a prescription filled until a certain date. So post-dating prescription is not permitted, but you can use the date issued and the do not fill before date. I always think it's funny that the patient name and address, except in a veterinary prescription, that's almost word for word from the statute. So I still think you have to have some sort of name and address, but that's the way the law is written. It's kind of unusual, but like my cat Diesel, and my address is what I think would be on the prescription, but I think probably veterinarians all do it differently. Another requirement for prescribers, again, is to issue an electronic prescription for Schedules 2 through 5. It's not required for Schedule 6, but it is requirement for prescribers to electronically prescribe 2 through 5s. So what do you actually need to fill a prescription? So just listed everything that the prescriber needs to do to issue the prescription. Now, what do you need to fill it? So you need, the no substitution language, the name and address. And again, you're going to need the prescriber MCSR number or the DEA number. You'll need one or the other depending on what is being prescribed. I want to call your attention to the signature part. So if you get a prescription, if you could get something that's a piece of paper with looks like a typed signature on it, that is not a valid prescription. A valid written prescription has to have a handwritten signature on it. A valid electronic prescription will be transmitted directly from the prescriber's computer to the pharmacy's computer, and you would never see it in print like that on paper. So just be aware that there's a difference between a handwritten signature and an electronic one. What do you not need to fill a prescription? So mid-level practitioners like physician's assistants and nurse practitioners, some of them need to have a supervising physician, some of them don't, but you don't have to hunt it down. If they are required to put it on the prescription, that is their job to do so. You don't need it in order to fill the prescription. MPI numbers are not required. MPI numbers are for human prescribers only. So veterinarians will not have an MPI number. So if you get a prescription from a veterinarian for a Schedule 6 drug, they're only required to give you an MCSR number. It might be that your computer system is looking for an MPI number, but the veterinarian is not going to have one. So you definitely do not need it. It might be helpful in certain circumstances, but it's not required. Obviously, number of refills, if nothing is there, then it's assumed to be 0, so it's not necessary for you to fill it. And an electronic prescription is not necessary for you to fill it as well. So you can always fill a fax, an oral, or a handwritten prescription that's on with tamper-resistant features. You can continue to fill that just as we always have in the past. And the reason for that is so that we don't have any delays in patient therapy just for the fact that the prescriber didn't issue that electronic prescription. And there could be any number of reasons why a prescriber didn't issue an electronic prescription. And we can go over a little bit of that later on. Label requirements. I'm not going to go over every one of these, but the same things as we talked about. With some of the prescription requirements, some of these are required, and some of them, well, these are the ones that are required actually. Oddly enough, the pharmacy phone number is not required unless you're a compounding pharmacy, which is kind of odd. You would think, everybody has the name and address and the pharmacy phone number on the label, and that's practice and the way it should be. But In accordance with state law, it only has to be there for a compounding pharmacy. Expiration date, USP requires 1 year from the dispense date or the manufacturer's expiration date, whichever is sooner, or a beyond use date if it's a compound. There's also a requirement in state law that if you're dispensing a compounded drug, that it has to say that it's either a sterile or a non-sterile compounded drug preparation, so that the patient and the end user know that this is not a FDA-approved preparation, that it's something that was compounded by the pharmacy. Okay. Moving on to advisories. Advisories, basically, they contain best practices or advice on how to meet a certain requirement. You can tell if it's an advisory and not something that's required by looking for the word should. If you should do something in accordance with these documents, then it's just a recommendation, it's not a requirement. So the first one we have is information for managers of record. So a manager of record that we all know have several more responsibility than the rest of the staff in a pharmacy. They have to make sure that all the licenses are up to date, not only the pharmacy licenses, but personnel licenses. Pharmacy technician and pharmacy technician trainee licenses expire on their birthdays, which make it very difficult to track. So the pharmacist manager of record needs to have some sort of system in place to make sure that they're checking that on a routine basis. They also need to develop schedules where ratios are always, where compliance with ratios is also reflected in the schedule. They have to make sure that inspections can go smoothly. So the manager of record should make sure that there's some sort of box or binder or some sort of area where all the inspection documents can be located, so that whenever there's a board inspection, which are unannounced, all these documents can be located in one place, so that when the inspector comes in, they can do their job more efficiently and not disrupt workflow. The goal for the inspectors is not to disrupt workflow. They want to make sure that they can go in, get their job done, and get out of your hair, so that they don't cause any more delays in your workflow. The manager of record is also responsible for making mandatory board notifications, such as, drug losses or, serious adverse drug event reports. So this document was updated with the new regulatory citations after the regulations were promulgated back in December. So have a look at that. Even if you're a current manager of record, it might be helpful resource for you. Sterile compounding advisories. We have a whole bunch of advisories for sterile compounders. So we have one about smoke studies and how to use the airflow pattern visualized by smoke in order to evaluate whether you have top-down dilution of air. There's 2 documents about environmental monitoring and remediation considerations. So if you have an action level, environmental action level in accordance with USP, what to do with that action level, things to consider when you're trying to remediate that action level, and what to do going forward. There are also documents on what to do if there's a failed HEPA filter in regards to recalls and that sort of information. There's recommendations for HVAC. So we recommend having an alert and an action level for HVAC. So if you see something that's trending upwards, such as, humidity or temperature, if you see it trending upward, you'll hit an alert level so that you'll know to do something before it actually hits the action level where, that might disrupt patient care. And media fills, there's also information about media fills and how to incubate and other details about media fill. The next group of documents are called policies. So policies are considered to be what we call sub-regulatory guidance. They're required and enforceable. So you'll see the words shall or must here, which means that you have to follow those particular requirements. So the first one is about Schedule 2 and 3 dispensing. So this was a change from the summer. This was a change to the state law, which finally got rid of the requirement to check for diagnoses for ADD or ADHD or narcolepsy. You no longer have to verify those diagnoses for stimulants. So you can now give a 90-day supply for any non-opioid in 2 and 3. So stimulants or testosterone and anything along those lines. Drugs that are used for the treatment of opioid use disorder can also be filled for a 90-day supply. So that would be any of your buprenorphine products. So though we were hoping to have this change so that patients can have more constant supply of medication for, stimulants and testosterone. It comes as a tough time where, stimulants are in short supply. So more than likely, people are probably still only filling these for a 30-day supply just because of the supply chain issues. But going forward, I think it'll be very helpful for our patients and not having to verify diagnoses and allowing a 90-day supply. The next policy you have is about defective drug preparations. So a defective drug preparation a log is required for every board pharmacy, board licensed pharmacy. So if you recall anything that's sterile or non-sterile, that has to be on a log and it has to be reported to the board. So even for a typical retail pharmacy that only does what we used to call simple or moderate compounds like Miracle mouthwash or just combining 2 creams together, if you dispense any of those would, and there was an issue with that, a defect with that, then that would also need to be placed on this log. Unfilled prescriptions. So the DEA does allow, I like to use 2 different terms here. So there's the forwarding of unfilled prescriptions and transferring of prescriptions after they've been filled. It helps me and my little tiny brain to be able to keep those 2 separate. So an unfilled prescription can be transferred to another pharmacy for the initial fill if it's an electronic 2 through 5, and then it can only be transferred electronically for those 2 through 5s. Because the DEA doesn't have any involvement with Schedule 6, we allow you to transfer any unfilled Schedule 6. So whether it's electronic or paper or oral or whatever, as a Schedule 6 drug, we have a little more flexibility here in the state. Going forward, you can only forward an unfilled prescription once, but you can still also transfer the refilled once for those federally controlled substances. Unfortunately, CMS, I don't think, has signed off on this functionality yet. So SureScripts has not been able to enable the function. So I don't think that this functionality is yet available for the electronic transferring. Hopefully that'll be happening soon so that pharmacies can use that functionality. Non-sterile compounding. So this policy has undergone a few changes since the USP 795 was finalized a couple of years ago. It seemed to have been written, USP 795 seemed to have been written for pharmacies whose core business was compounding. But as we know, USP 795 also applies to your typical retail pharmacy. So those requirements for sanitizing, USP sanitizing and cleaning requirements and temperature monitoring, the board is not going to enforce those in your typical retail pharmacy if the pharmacy is otherwise clean and sanitary. Carpeting is not recommended according to USP, but again, we would not enforce that in your typical retail pharmacy if the pharmacy is otherwise clean and sanitary. We would not expect to see carpeting, however, in a pharmacy that does complex non-sterile compounds, so a pharmacy that does, capsules or transdermals or hazardous drug compounding, though. USP does call out that pre-measured compounding kits and adding flavoring are considered compounding. So you want to make sure that you have documentation in place for those things. So this policy does go over, you can do a log sheet and what elements of that log sheet would needed to be present in order for you to document pre-measured compounding kits and flavoring. Because flavoring, again, is considered to be compounding, you want to make sure you add it to the patient's prescription and you add it to the patient's label as well, so that the final patient, or the end user knows that there was flavoring added. And you can also add it to the prescription without having to contact the prescriber for any reason. It can always just be added to the prescription. Continuity of care. So I'm sure everybody's run into that Sunday night thing where, somebody's looking for a refill, you can't reach the prescriber. You can issue a 30-day supply if you can't reach the prescriber in a timely manner for any Schedule 6 drug, except for gabapentin. You can only do it once, however. And for those prescribers who are no longer practicing, maybe they've retired or maybe they've passed away or whatever reason, Any prescriptions they issued while they were still in practice, if they were otherwise valid, you can still continue to fill or refill those. Prescribers are often encouraged to issue continuity of care prescriptions until a patient can establish a relationship with a new prescriber. So those are absolutely able to be filled. You'll absolutely need to use your professional judgment in case something else is going on, but you can absolutely continue to fill those. Vaccine administration. So the PrEP Act, the Federal PrEP Act is now completely done and over with. The provisions, none of the provisions are ongoing. So now only qualified pharmacy personnel can only administer vaccines to patients as young as 5 and older. So that Federal PrEP Act allowance for 3 years is gone, and now it defers to state regulations, which are 5 years and older. So qualified pharmacy personnel will be any trained personnel who's a pharmacist, intern, or a pharmacy technician. So what can a pharmacy technician do? They can only prepare and administer vaccines and emergency medications. They cannot select the drug. They cannot review the prescription. All of that still belongs to the pharmacist. The pharmacist still has to choose the drug, still has to finalize the prescription. Technicians are also required to have 2 hours of updated training or education every 2 years. Whether it's ACPE or not is up to that particular technician on what they would like to use as their continuing education. I could probably almost hear the groans in the audience saying, oh my God, this person talks about these continuing education requirements every year. Yes, I do talk about it every year because yes, we do continue to get questions every year. So continuing education is required by law to be 20 contact hours every calendar year. That doesn't mean you can do 40 in 2025 and then none in 2026. It means 20 every calendar year, and that's outlined in state law. Other regulations, however, have come to say, well, we need some live contact hours so that you have some of that back and forth information from a person who's presenting. You need to have 2 hours of pharmacy law every year, and you can only do a maximum of 8 credits a day. So there are several approved programs that you can use. The AMA, PRA Category 1 are the physician credits. Category 2 are not permitted, but Category 1 are. This policy also goes over what kind of duties would require specific credit hours. So if the state law says if you engage in or oversee sterile or complex non-sterile compounding, you need to have credits in those areas. So this policy will go over and give you some examples on what exactly that means. Immunization, if you're involved in immunization as well, you need an hour of that as well. So all of these specific credits can be part of the 20 per year, except for CDTM pharmacists who have to have an additional 5 every year. So they need 25 every calendar year. As far as compounding credit goes, the ACPE compounding credit is not specific for sterile or complex non-sterile compounding, as our state law requires. So we have offered some program titles that can be used for you to help when you're searching for an appropriate program. So you would look for sterile or IV or USP 797 or something to that effect. However, if you do come across a course that you think, oh my God, this totally should count, please email us. Let us know the program number and give us a copy of the objectives, and we can absolutely look at it and determine whether it would count as well. We also have a policy regarding scope of practice. We are trying to pull all the scope of practice issues out of regulation and put them into policy so that as practice evolves over time, we can update the policy and make sure everyone can always practice at the top of their license. Some things to note is that, pharmacists can administer certain injection, and that is generally outlined in state law. So pharmacists are able to give substance use disorder medications, mental health drugs, COVID therapeutics, vaccines, but that's really about it. So pharmacists can't give penicillin skin tests. They can't give hormone injections. They can only administer certain things that are outlined in state law. Pharmacists can do certain health promotion screening tests and COVID-19 tests, but state law does not allow us to do yet, hopefully yet, does not allow us to do flu or strep tests. or anything in that vein. So just be aware that, pharmacists don't have the authority to diagnose medical conditions, but you obviously can offer symptom management for anything that your patients may present with, sore throat, or, anything in that general vein. You just can't diagnose. Permitted prescription changes and additions. So pharmacists can change day supply. So in general, Schedule 6 medications, quantity medications, are not dictated by state law or regulation. They're generally dictated by insurance. So if you get a prescription for, say, metformin for a 30-day supply with, 11 refills, you can issue a 3-month supply with 3 refills if that's what the insurance is preferred. Obviously, we can't do this with gabapentin. Gabapentin's always kind of like that outlier that you can't apply the Schedule 6 rules to. So just to be aware, though, if you have any behavioral health drugs or narrow therapeutic index drugs, you may want to speak to the prescriber before changing it automatically, even just based on insurance. We have had prescribers who have been concerned that certain patients have gotten a 90-day supply of antidepressants when their patients have not yet been stabilized, and there has been some concern along those lines. So just use your professional judgment when you do this sort of thing. Circular letters. Circular letters are basically the equivalent of the board's policies. So the board has a sister agency called the Drug Control Program, which basically they control drugs. So they license manufacturers and wholesalers, and they also issue the requirements for prescribing and prescribers. So they kind of do a lot that also falls into the realm of, pharmacy licensees. So again, their circular letters are considered to be, similar to the board's policies. So there's sub-regulatory guidance that is considered to be required. The access law to birth control and emergency contraception. The birth control patients can access a 12-month supply of birth control after a 3-month trial period. You may not have 12 months supply on hand if a patient comes in looking for that, but you can always order it and complete it in one transaction. If you're not sure if their insurance will cover 12-month supply, just run it through. If the insurance covers it, you can absolutely dispense that 12-month supply. So remember, Schedule 6 quantities are generally dictated by insurance and not by anything else. Emergency contraception, pharmacists do have access to a statewide standing order that calls out some of the FDA-approved emergency contraceptive pills. The statewide standing order also offers antiemetics should the patient want a specific antiemetic. There is no requirement for a pharmacist to dispense emergency contraception, but clearly it would be a help to our patients in order to do so. Contraceptive prescribing can be done by any pharmacist, and they may prescribe contraceptive pills or patches, but that's it, just pills or patches. And it could be OTC or prescription. It can be any person of childbearing age. There's no age minimum. This is the one instance, however, where an MCSR number is not needed. That mass controlled substance registration is not needed for a pharmacist to prescribe contraceptives. But in this case, you do need an MPI number in order to affect billing for it. Mass Health also requires you to register as a non-billing provider if you choose to participate in contraceptive prescribing as well. Training program is required, as well as the issuance of a self-screening tool to the patient to try to help you evaluate whether they're a good candidate or not. Electronic prescribing and dispensing. As I mentioned earlier, there are a whole bunch of exceptions to electronic prescribing, none of which you have to verify if you get a paper prescription. The biggest one there, I think, is the temporary electronic failure. So anybody could say, I had a computer problem, so, they'll just issue a paper prescription. And, like I mentioned earlier, you can always fill a paper or fax prescription. There's an old requirement now there on the book still that says you have to sign the face of a Schedule 2 e-prescription. The way to do that is just to verify in the system that that Schedule 2 prescription. There's no need to print it or sign it or anything along those lines for the electronic prescriptions. There's also something called a failover. So that's when a Schedule 6 prescription is written and there's a defect in the system and it winds up coming into your pharmacy as a fax. That is not a valid written prescription because there's no handwritten signature on it. It just has that little typed name. That's not a valid signature. So because it's not a valid written signature, it can be considered a valid oral prescription. So if you're otherwise comfortable with the prescription, you can go ahead and fill it without any further contact with the prescriber. If you're not, you can simply call the prescriber and verify that that's what they wanted and they intended for this to be a prescription. And again, I just want to reiterate, if you have a valid oral written prescription, fax prescription, you can absolutely fill it. There is no change from the olden days when that's all we had before electronic prescribing was an actual thing. Any of the documents that we talked about earlier also have at the end who to contact for questions, and the circular letters that I just mentioned also have that at the end too. And these are the drug control program's email and phone number in case you have any questions about any of the documents that I just talked about. So now I'd like to go ahead and introduce Julienne Tran. She's one of the pharmacy investigators, and she's going to speak about common deficiencies in pharmacies. There you are.
Thank you, Michelle. So good morning, everyone. My name is Julienne Tran, one of the pharmacy investigators for the Board of Pharmacy. I just wanted to share some of the things that the investigators have seen on the road and share it as a learning opportunity for all of you. I think one of the biggest things during an inspection is that they're unannounced, but the important piece of that is to make sure that you are organized. Many times when we come in, the investigators don't, usually see the manager of record at the pharmacy working on that day. So I think it's important to make sure that you have some sort of organization system for all the different paperwork and documentations that you have in a segregated area of the pharmacy, and that you have everyone in the staff aware of where the information is, just so that it cuts down on the paperwork, even for floaters. As you can imagine, when floaters or personnel are covering for your pharmacy, they may not know, the staff or where everything is within the pharmacy. So it's important to have some sort of organization system so that everyone knows where things are. Additionally, since we're starting with a new year, I think that it's always important to mention that the divisions that we see, the compliance inspection tools, for the sterile, the non-sterile, and the retail compliance inspections are all available on the board's website. And we encourage and strongly recommend that all of you perhaps have one of the pharmacy interns that is doing their API or IPI rotation at your pharmacy to complete a self-inspection for the pharmacy. So they, do a mock self-inspection of the pharmacy to ensure that everything is in compliance in the pharmacy, and then use it as a learning opportunity to maybe brush up or organize some of your documentation so that is all in place. So each year, the investigators conduct about 2,000 inspections annually. And time and time again, the list of common deficiencies usually remain the same. They kind of change the order, but this is the core list of things that we usually see in the field. So one of the things on the list is perpetual inventories. As you all know, and I am the first one to say it, then when I was working, perpetual inventories was my least favorite task to do. But it's one of those things that you need to do to make sure that you have control of all your schedule and medication. So that should ideally be done every 10 days, and make sure that you have rotating staff. In the event that somebody is volunteering to do it every week for you, that might be a red flag for the pharmacy and the manager of record to take a look at. It's always better to have different eyes counting the medication each week so that there's different perspective on it. And if you have a loss, that you make sure that you do the investigation to find out why that loss occurred before it gets too late and it makes it more difficult to investigate. Biennial inventories, we do this every other year, and sometimes, the paperwork gets lost when the investigator goes in. So again, this just goes back to having some sort of organization system or a box to put all your important documentation in so that the inspection moves more quickly and that the investigators can get out of your hair. Refrigerator issues. Now that we're in the thick of immunization season, especially in the thick of flu and COVID, this is especially important to ensure that the staff has a designated person or persons that is monitoring the refrigerator temperatures at least twice a day. If you're doing immunizations, we know that everything in the medications that are in the refrigerator are high-priced items, so we want to make sure that the medication is stored properly and to ensure the safety and stability of the medication. And if for any reason the refrigerator goes out of temp, that you make sure that you don't ignore it and that you investigate why. So if the temperature is reaching 75 degrees, you might want to make sure why. Perhaps somebody's putting an order away and they have the refrigerator door opened, and so now the temperature is creeping up. So you just want to make sure and be vigilant about refrigerator issues and make sure that there is a staff constantly monitoring that, whether you are a pharmacist or anybody else is not there, that there's a plan in place. Pharmacy staffing, you just want to make sure that you adhere by the ratio, 1 pharmacist to 3 support personnel, one of which has to be either a CPHT or an intern, or 1 to 4 ratio where at least 2 has to have an advanced license, either a CPHT or a pharmacy intern. And then also compounding records. If you are making a magic mouthwash, you want to make sure that there's a copy of a compounding record in a binder with all the necessary information. So if the investigators come in and ask to look at the compounding records, you can provide them with the documentation that they need to include all the information that is required for the compounding records. Next slide, Michelle. The additional deficiencies that we've seen is compounding copies of commercially available drugs. So if you are making something that is currently available, please make sure that there is a documentation on the prescription of why compounding of that product needs to be completed. Perhaps the patient has an allergy to a specific dye, or they have a G-tube and they can't take certain medication or interacts. Whatever the reason, there needs to be a documented medical need on the prescription, and price is not a valid medical need to commercially compound a product that's already available. Untimely MOR change notifications. We have seen an increase of cases where the MOR has left the company for another opportunity, but have failed to notify the board that they are no longer the MOR. And this is important because if you have left, that there is proper notification. So if there's anything that happens after you leave, it doesn't go back on you. So we have a very helpful MOR advisory to help you walk through what the different documentation and change notifications need to be completed on the board's website. Also, incomplete records. If you are compounding, there's a specific disposal process of the compounded preparation and active pharmaceutical ingredients. They should never at any time be thrown out with the regular trash, like with your paper, and left on the street. And unfortunately, we have seen this happen. There needs to be a return process back to your distributor or whoever you have for disposal purposes. Additionally, there is expired PT and PTT licenses. There is no grace period with it. And again, you cannot practice with an expired license. And additionally, with the immunization season in rampant, it's important to note that a lot of pharmacies now are accommodating with immunization rooms and epinephrine and all the immunization supply. Even the medications cannot be placed in that immunization consultation area because it's not considered part of the pharmacy proper, and patients can traverse in that area. So it's important that once you provide immunizations for your patients within that immunization consultation area, that you bring all the supplies, the medications, and emergency medications back inside the pharmacy. And just for time's sake, we will go through this pretty quickly, but no, nothing says it like pictures. So here you can see that this is a fill master. There's some mold at the bottom. This could use some cleaning. And this is a picture of a non-sterile compounding equipment. The picture on the right shows the machine after it's been cleaned, but that piece of paper on the left side is all the dirt and soot that was in that equipment. And this is a picture of a non-sterile compounding pharmacy. As you can imagine, there was an area of cleaning that they missed. And this is my favorite. Now, this is not the New Hampshire ice castles. These are freezers in the pharmacy. So we should never let it get to this stage. And it's important, just like the refrigerators, to make sure that you are constantly checking your equipment and making sure that you clean and defrost your freezers as well. And this next slide is, I think, by far my favorite. One of the investigators on the road found in the red freezers I think there was some marinated chicken. I understand the pharmacists are great at multitasking, but marinating your food in the med freezer for dinner is probably not a good idea. And this was a great picture of a pharmacy sink. The sink needs love too. So especially if you're compounding and using it to wash your hand in the pharmacy, please give the sink some love and make sure that it's cleaned on a daily basis, or at least on some sort of basis to make sure that it's clean. This one was a picture of as you could see, unlabeled vaccines in the right-hand side that was for future use. This was not done under sterile condition. And the blue thing on the left-hand side was a dehumidifier draining into the sink right next to the pre-filled syringes. And this is a picture was in a sterile compounding room. This was in the ante-room sink in the ISO 8 area. As you can see, there was a buildup of on the drain connection, and there was actual water coming out when it was in use, when the investigators came in for an inspection. So we're just gonna try to go through this quickly, and we ask that you don't put it in the chat box so that it dilutes some of the questions that you may have already asked. So if you could just write it down on a piece of paper or just put a mental note. So which of the following is true regarding regulations? Maybe waived by the board, provides an overarching mandate issued by the board, or anyone can provide public comment. So if you could just put a mental note, and the answers are A, C, and D. Thank you, Michelle. And this one is a prescription, and hopefully you remembered a few things that Michelle had spoken about regarding prescriptions. So we are going to look at this prescription and have a follow-up question regarding the prescription. So this is a handwritten prescription you received today. What is missing or incorrect? Can you find it? Michelle, if we can populate the answers. So today's date looks like it was post dated, 11 days ahead. And the partial fill upon request is required for C2, but the language can be added by the pharmacist if it is missing. The NP is required to add the supervisor's name. They must do so, so a pharmacist can fill it in there if there isn't one. But again, not all nurse practitioners need a supervisors. The next prescription. Again, you received this paper prescription today at the pharmacy. What is missing or incorrect? And can you fill it? If we could populate the answers, please. So there's a few things that are missing here, and it cannot be filled because it is over 30 days old, and it does not have a handwritten signature on it. There are other issues, so the DEA number needs to be added on the prescription. There is a max 90-day supply for non-opioids, which this goes over, and paper prescription does require a handwritten signature, and this one clearly does not have one. And this prescription is something that you receive again today. What is missing or incorrect, and can you fill it? If we could populate the answers, Michelle. So this cannot be filled in Massachusetts because the prescriber is currently in North Carolina. And as you have heard Michelle say, C2 opioids from contiguous states and Maine are the ones that we can only fill in Massachusetts. If this was a non-narcotic Schedule 2, it could be filled. The other issues is this prescription is over 5 days old. We would only be able to accept a Schedule 2 from another state within 5 days of issuance. And again, there are no refills for Schedule 2 prescriptions. Also, there is a 7-day limit for the prescribers, but not the pharmacists, so they can write for more, but they need to make sure that they document in the patient's record. And also the full quantity can be filled if you are otherwise comfortable with it. And again, the partial fill language is only needed for a Schedule 2 narcotics, but you can add it if it is missing. So this is another CE opportunity through the Department of Public Health to provide disability awareness. Again, this is sponsored by the Department of Public Health if you are in need of additional CEs. And also, we have a new program called URAMP, which is the Unified Recovery and Monitoring Program. This program is an alternative to disciplinary recovery program, which replaces our pharmacy substance use disorder program. And for those who may have substance use disorders or impaired mental health conditions, if you need more information or a referral, and more information can be found on that website below. We have a wealth of information on the Board of Pharmacy website, all the contact information, news updates, and board meeting. We have a board meeting coming up on 2 days on February 6th. So we invite all of you for even interns or pharmacy technicians who are interested in learning more about the board and what a board meeting is. All the information is provided at the link below. And after a very long time, the Massachusetts Board of Pharmacy does have a newsletter that is available to all of you that you could be put on the distribution list. Michelle is the great editor for this quarterly newsletter, so it has a lot of great information if you want to be on the distribution list. And then this is our contact information. And then we could just move along to the next slides. These are all our different references available on the pharmacy's website. And, you know, I understand that we're kind of over time, and just to be cognizant and be respectful of everybody's time, there is the code there. But if you have any practice questions, and I know there's a few in the Q&A box that we are haven't been able to answer, please feel free to email all your questions to pharmacy.admin@mass.gov so that we could provide a response to all of you. Thank you very much for having us today.